My name is Dwomoa, and I'm really grateful to the Africa Healthcare Network and the International Society of Nephrology for inviting me to talk at this Fireside meeting and to talk about chronic kidney disease. And I'll be talking on behalf of a lot of colleagues in collaborative studies, and in particular, I remember Jacob Plangu started with us, but unfortunately died, and I have no disclosure.
Welcome to everyone attending this evening. My name is Dr. Amar Swali. I'm a consultant nephrologist and physician working with Sri Hindu Mandal Hospital in Dar es Salaam, Tanzania. And I take great pleasure in, first of all, thanking the ISN for collaborating with the Africa Healthcare Network tonight in providing us with such a high-impact speaker, that is Dr. Dwomoa Adu. Dr. Adu is the former president of the African Renal Association. He's also the honorary consultant nephrologist at the Korle Teaching Hospital and a senior research fellow at the University of Ghana Medical School. He is also the co-principal investigator at the H3 Africa Kidney Disease Research Network that is funded by the NIH, studying the genomics of CKD in Africa. He is also a former consultant nephrologist at the Queen Elizabeth Hospital and a senior clinical lecturer at the University of Birmingham, England. His talk tonight with us will be on chronic kidney disease in Africa. And Africa encompasses several geographical zones, and therefore the causes of CKD in sub-Saharan Africa differ significantly from the causes in North African countries because of the differences in ethnicity as well as the geography. The allolipoprotein L1, the APOL1 variants, which are common in West Africa, predispose to an increased risk of chronic kidney disease. There are also geographical differences in the etiology of CKD, with schistosomiasis, for example, being located to areas where there are rivers and lakes. A meta-analysis done in 1984 found a prevalence of CKD in sub-Saharan Africa at about 14%, and a study in Ghana reported a prevalence of about 13.5%, which was comparable to the study done before. The most common causes of end-stage renal disease in Africa include hypertensive renal disease, end-stage renal disease of an uncertain cause, diabetic nephropathy, glomerulonephritis, and HIV-associated nephropathy. Differences in the frequency of nephritogennic APOL1 variants influence the risk of developing CKD, and this talk focuses on the role of these variants in the APOL1 gene and chronic kidney disease. It is my pleasure to hand over to you, Dr. Adu, to take tonight's chat forward. Thank you so much for being with us.
Dr. Amar, thank you very much for this very kind introduction, and in my enthusiasm, I almost jumped the gun. So I'm delighted to talk at the Africa Healthcare Network Fireside Chat, and also sponsored in part by the International Society of Nephrology. The ISN participates in these Africa Healthcare Network Fireside Chat, and it really is an important organization in terms of advancing your profession, making a difference, connecting, and also it's the older Global Nephrology Society advancing kidney care worldwide, and without kind of unduly promoting it, I think we can all make a difference if we work together within the ISN. So end of promotion. As Dr. Amar kindly said, I'm a co-principal investigator of the Human Heredity and Health H3 Africa Kidney Disease Research Network, funded by the NIH, and also the welcome to improve genomic studies in Africa, and we started our work some 10 years ago. And the aims of my talk will be to try and give some understanding of the prevalence and causes of chronic kidney disease in Africa, to understand the evolution and genetics of apolipoprotein L1, APOL1 for short variants, to recognize kidney diseases associated with these APOL1 variants, and then the role of APOL1 variants in kidney transplantation. I'll end up with just 2 slides about potential for treatment of APOL1 mediated kidney disease. So I'll be talking about chronic kidney disease, the evolution of APOL1 variants that were involved in an evolutionary arms race between mankind in Africa and trypanosomiasis. And as one of my research assistants said, aptly, what kept our ancestors alive 10,000 years ago is killing us now with kidney failure. And nature has a way of taking back what it gives. Chronic kidney disease is common in Africans and African Americans. And in Africa, individuals tend to succumb to end-stage renal disease 20 to 30 years younger than the median age of onset of end-stage renal disease among Europeans. And this is the meta-analysis carried out by Senefer almost 10 years ago now, right across Africa. And this shows the prevalence of chronic kidney disease of around 14%. This is all CKD of around 14%. And actually, the striking thing, though, about chronic kidney disease in Africa, and this is data from the Ghana Renal Registry, that the median age of onset was 45 years. And whilst in the United Kingdom, and this is taken from 15 odd years ago, but I'm sure it hasn't changed, the median age of onset of chronic kidney disease was in the 60s and 70s. So they're really striking. Working in Ghana, most of the patients that come to our chronic kidney disease clinics or dialysis clinics are young, whereas in the UK, they were all old. They were over 60, 70, or even higher. And in Ghana, again, we looked at the prevalence of chronic kidney disease and found that it was overall 13.7%. Again, interestingly, when Ghanaians migrated, so Ghanaians in the Netherlands, in Germany, and in the UK had a lower prevalence rate of chronic kidney disease. That's almost certainly because they had early identification and better care. And the causes of chronic kidney disease, and I'm showing this for Ghana, where I am, the vast majority have hypertension, 37.8%, diabetes in 9.2%, glomerulonephritis 7.7%. We have a large proportion of chronic kidney disease of unknown etiology of 28%, and then 3.8% with HIV-associated kidney disease, and then the others were about 13%. So end-stage renal disease in sub-Saharan Africa, prevalence of around 14%. Most of the patients are young, and hypertension is the most common cause, followed by CKD of unknown etiology. And actually, almost all our patients present with really quite advanced end-stage renal disease. Mostly are untreated, and if dialysis is not affordable, which it often is not, they'll die from the disease. So it's a different disease in many ways than is seen in more advanced countries. So I mentioned most of our patients are young and have hypertension, and they're often untreated. Now, what is the link between kidney failure and trypanosomiasis, one might ask? So Trypanosoma brucei rhodesiense is prevalent in East and Central Africa. Trypanosoma brucei rhodesiense, its transmission involves a large spectrum of reservoir animals, but often cattle, which have been domesticated. Whereas Trypanosoma brucei gambiense is prevalent in West Africa, and that's predominantly a human tetefly cycle without an intermediate host. And again, just remind you that tetefly, found in mostly forest areas and savanna areas in Africa. and it causes a disease that, if untreated, is fatal, with some 70,000 or so cases prevalent in Africa each year. Now, I'll try and link that trypanosomiasis story with chronic kidney disease in a few slides. So the story really started in the USA, that it was been noted for a long time, even 20, 30 years almost, that African Americans have a 3.7 times higher age-adjusted risk of end-stage renal disease as compared with European Americans. And studies using the mapping by admixture linked disequilibrium technique showed that polymorphism in the apolipoprotein L1 gene on chromosome 22q12 were associated with chronic end-stage renal disease. So the MAL technique, the mapping by admixture, attempts to localize disease variants to either African or European genes. And by doing that, they could map down the areas where the disease gene, the chronic kidney disease gene variants were to the African part of the gene in admixture studies. And again, this is because of this horrible slave trade between 1650 and 1860. Approximately 50 million Africans were transported to the Americas, North America, South America, the Caribbean, as part of that slave trade. And this actually shows Elmina Castro. It looks scenic, but it's a source of real horror, built in the 1490s and played a major part in the slave trade. Anyway, to get back to ApoL1, so by admixture mapping, they could highlight the chromosomal region that carried the disease, and then using data from the 100,000 Genomes Project, Genovese and colleagues from Martin Pollack's lab were able to show that ApoL1 variants were associated with focal segmental glomerulosclerosis, and the condition that's found only in primates, the recent evolution of this gene. And then also a group from Professor Korecki's team, again in the USA, Shea being first author, showed that missense mutations in the ApoL1 gene were associated with end-stage kidney disease previously attributed to the MYH9 gene. So why did these variants arise? So Trypanosoma brucei rhodesiense evaded the trypanolytic effect of ApoL1 using a serum-resistant A protein. And one allele of either ApoL1 G1, ApoL1 G1, or G2 variant overcomes this resistance and is trypanolytic to Trypanosoma brucei rhodesiense. And the association between ApoL1 variant and protection against trypanosomiasis is complex, and I won't go into that. Now, these ApoL1 variants, as I've mentioned, conferred resistance to trypanosomiasis. So humans with trypanosoma, infected with Trypanosoma brucei rhodesiense, humans were resistant to Trypanosoma brucei rhodesiense. However, Trypanosoma brucei rhodesiense, when that evolved, it produced a serum-resistant A protein, and therefore humans became susceptible to TB rhodesiense. So it has evolved a serum-resistant A protein that meant that it was resistant to apolipoprotein L1, and therefore humans succumbed to the trypanosome and then developed sleeping sickness and died. And with the generation of these ApoL1 variants that was able to bypass the block from the serum-resistant A protein, caused lysosomal swelling, and the parasite therefore died. So these variants evolved some 10,000 years ago. I've mentioned they provided resistance against, protection against TB, rhodesiensis, a bit like sickle hemoglobin and malaria, and therefore they rose to a high proportion in Africans. And this was after the out of Africa migration of Homo sapiens some 52,000 years ago. And it therefore means that these variants are found only in Africans and people of African descent. So with the slave trade migration, the APOL1 variant spread to the Americas. And as I said, the variants evolved after the out of Africa migration. And so they're only found in Africans and people of African descent. So the variants kill, these are trypanosome, the variants in vitro kill trypanosome 1 variant or G1 or G2. And then by law of unintended consequences, the same gene variant cause damage to the kidney, in this case, a focal segmental glomerulosclerosis. So shown graphically, there were missense mutations in G1 either in these two positions or a 6 base pair deletion for G2. So G1 were missense mutations, G2 variant was a base pair deletion. And individuals without these variants died 5 to 10,000 years ago from sleeping sickness. If you had one risk allele, you were protected from getting trypanosomiasis. If you had two risk alleles, you were protected from getting trypanosomiasis, but unfortunately developed chronic kidney disease. And, back in those days, succumbed. And again, looking at the prevalence, and I'll just go over this very briefly, of these G1 and G2 variants that I've described, they're actually more common in West Africa than in East Africa. So red is a 35 to 50% prevalence in the population, 20 to 35% prevalence. And you can see that the red dots are all in West Africa for the G1 variant. And then the G2 variant, again, is much more common in West Africa, 10 to 20%, maybe even higher than in East and Central Africa. And that's interesting because Trypanosoma brucei rhodesiensis is more common in East and Central Africa. Gambiensis is more common in West Africa. So they've expected to see more APOL1 variants in East and Central Africa. And I think this must reflect human migration over the last 5 to 10 years. And that hasn't really been properly studied. And these APOL1 variants are associated with HIV-associated nephropathy with a high odds ratio that's in South Africa, odds ratios of in the 20s with single diseases. So focal segmental glomerulosclerosis, HIV-associated nephropathy, hypertensive end-stage renal disease, non-diabetic chronic kidney disease, lupus, but actually not with diabetic kidney disease. So the APOL1 variant is associated with non-diabetic chronic kidney disease. And looking at progression similarly, individuals with 0 or 1 allele, this is progression to end-stage renal failure, progress slowly, whereas individuals with 2 risk alleles progress rapidly. So it's a recessive, autosomal recessive condition. You need 2 risk alleles to get CKD, but you only need 1 risk allele to provide protection against trypanosomiasis. Okay, so I mentioned it's located on chromosome 22. It's produced in the liver and circulates with high-density lipoprotein HDL3. The 2 risk variants I've mentioned, and it explains some, if not all, it doesn't, some of the excess risk of genetic risk of chronic kidney disease in African Americans, and we're now showing in Africans. So obviously not all Africans or African Americans with two APOL1 variants develop chronic kidney disease. So we must have an etiologic second hit, gene or gene environment. And so far, the strongest gene environment interaction has been with interferon. And of course, interferon levels are high in individuals with HIV, and they again have the strongest APOL1 association with chronic kidney disease. And this is just a brief overview, and I'll take just a minute to talk over this. The AFRCP Kidney Disease Research Network, and we recruited 4,000 CKD cases, 4,000 controls, done GWAS. I won't have time to discuss that. We then recruited individuals into a cohort study where we tried to recruit 3,500 to follow up. And then latterly, we've been looking at childhood nephrotic syndrome and sickle cell anemia and the role of APOL1 variants in causing either the nephrotic syndrome or causing disease. And we've actually also done studies on pregnancy, APOL1 variants associated initially with preeclampsia. We've done studies on SARS-CoV-2, I wouldn't have time to talk about, capacity building, and then also involved in community engagement. And the AFRCP sites have been in Ghana, Nigeria predominantly, the studies I'll be reporting, but also recently set up in Cameroon and in South Africa. And we've done comprehensive phenotyping, and then genotyping of CKD cases and controls, at a strong emphasis on training, and then also on make sure that all sites had ethical approval. And we've studied, and I'll show you some data on the gene variants of APOL1 associated with chronic kidney disease, and a little bit of population variation across Africa. But I'll focus really on the gene APOL1 variant associated with chronic kidney disease. I've mentioned the two variants, G1 and G2, and these were genotyped by a custom Tachman assay. And we thank Cheryl Winkler and Barry Friedman, who did most of the genotyping. So the data that I'll be showing you comprises individuals with chronic kidney disease, i.e. GFR less than 60 with or without proteinuria. We've extended it to look at individuals with chronic kidney disease, GFR between eGFR between 60 and 89, and an eGFR greater than 90, as well as people who had a kidney biopsy. And we've assessed the APOL1 risk status association with chronic kidney disease using logistic regression, and we corrected for age, sex, BMI, blood pressure, HIV status, diabetes, language groups, etc. So the data that I'm going to be showing you will mostly be covariate adjusted logistic regression, and assess the association of APOL1 haplotype with chronic kidney disease. It's a rather complex slide. So I mentioned the group, one who had quite advanced chronic kidney disease, 232, GFR 30 to 59, 360 to 89, 4 greater than 90, they were the controls, and group 5 are the glomerulonephritis group. And actually, as defined by GFR, these could be categorized, and then the individuals were also categorized for proteinuria. And again, just this last line in yellow, I want to show you that the APOL1 risk variance in individuals with normal kidney function, GFR of greater than 90, was 25%, whereas in all the CKD groups, the APOL1 variant range is around 30% or more. So APOL1 variants were more associated, two variants were more associated with chronic kidney disease. So again, I'll miss this slide out. So this slide demonstrates the association between APOL1 risk variant and chronic kidney disease as compared with individuals with an EGFR greater than 90. So if you take the adjusted risk of chronic kidney disease with the ACR included, so APOL1 variant, the odds ratio for an association with chronic kidney disease for two variants versus one or no was 1.35. Now significant. The group 2, who had a GFR between 30 and 60 is 1.3, and group 4, 3, 60 to 90, 1.27. And then this is a group with glomerulonephritis. So all the CKD groups had an upwards of 30% increased risk of developing chronic kidney disease if they had two APOL1 risk alleles versus 1 or 0. Now, the G1 haplotype frequency was much higher in West Africans at 37.5% than the G2 of 13.68%. And I've shown you that the prevalence of APOL1 high-risk carriers, i.e. those with two APOL1 variants, was significantly higher among patients with chronic kidney disease of 30.6% than those with normal kidney function of 25.9%. And we found an association with these high-risk carriers of odds ratio of 1.34. So that was highly significant. We had no differential effect of APOL1 CKD risk in patients with diabetes, and the risk of CKD from APOL1 seemed to be lower in African than in African Americans. We're not sure whether that's genetic admixture, haplotype background, or environment. And we're now studying that. I've got a study with a group in America. So what is the role of migration? I said the variants protect against TB rhodesiense, which is commoner in Central and East Africa, but the protection, the variants are found several-fold more commonly in West Africa. And so there must be migration, and we haven't studied that. I'll just talk very briefly about a follow-up, a cohort study following up individuals with glomerulonephritis and chronic kidney disease by the APOL1 status. So with that, we tried to study HIV negative African Black and to evaluate the contribution of these APOL1 risk variants to progression. And then we've also wanted to look at gene environment interaction and then develop a biorepository of gene of kidney data and biospecimens for future studies of kidney disease. And so far, we actually ended the study. We recruited 706 patients who had glomerulonephritis and had a kidney biopsy, and 2,600 patients with chronic kidney disease who did not have a kidney biopsy. And I acknowledge Jeff Hodgin at University of Michigan, who did most of the biopsies. Some were also done at Massachusetts General Hospital in the USA. And we got really good histology, showed somebody with membranous, showing the spikes on the glomerular basement membrane, good immunofluorescence, and also good EM pictures. So we were able to really get good histology. And of the biopsy, there was 35% have focal segmental glomerular sclerosis, 17.5% minimal change, and then 9.7% membranous, and then the others. And so looking at the association between APOL1 high-risk alleles, that 2 versus 1 or not, the only condition that was associated with these APOL1 risk variants was, as shown tried in this format before, was focal segmental glomerular sclerosis, where we found that the odds ratio of an association was 1.85, and this was significant. So with all the other conditions, minimal change, membranous, lupus, and other GM, we did not find an association. So again, this shows it in tabular form. So focal segmental glomerulosclerosis was significantly associated with high-risk APOL1 variant. We now have an ongoing longitudinal cohort of chronic kidney disease subjects that I think about 2,500. We've got this repository now of good biochemistry and biochemical and histological DNA data and kidney biopsies on over 700 cases who had a biopsy. And then of the glomerulonephritidis, as I've mentioned, only focal segmental glomerulosclerosis was significantly associated with APOL1 high-risk variant. Now, I'll talk briefly about APOL1 variant and renal transplantation, because that's has been a source of quite considerable anxiety. And there's a big long-term kidney transplant outcomes network study, the Apollo study, that's currently studying the effect of APOL1 variant on kidney transplant outcome. So the initial view and the initial publication suggested that APOL1 inverted commas toxicity to the kidney was transmitted with the donor. So if you had a donor with two APOL1 risk variants who gave a kidney to a recipient, then the recipient was at increased risk of developing transplant glomerulopathy. Whereas if you had a recipient who had two APOL1 risk variants and they had a kidney from a donor who had not or one, there was no apparent effect on allograft survival. So it seems simple that the disease travels from the donor kidney. However, just tail end of last year, earlier this year, and it's a slightly complex study, but what that showed was correcting for donor APOL1 variant. The recipient variants were also associated with reduced allograft survival. And this showed time allograft survival with no risk variant, one risk allele, and two risk alleles. Now, so this data suggests that individuals with two APOL1 risk variants will also have reduced renal allograft survival. And that's actually a real headache. And, some transplant units are genotyping donors and then thinking about what to do in terms of whether to go ahead with the transplant or not. And I think the Apollo study is adequately powered. And I think we should wait for the results of the Apollo study before we take decisions about APOL1 variants and renal transplantation. Anyway, that's the advice we're using. So again, we've had a huge training program, clinical research training, MPhil, PhDs, Master of Science. Two of our clinicians did a Master of Science in Human Genetics, and then an administrative program, and then training for clinical coordinators and data clerks. And then for the kidney biopsy, we actually held 2 training sessions for for 40 faculty in Ghana and Nigeria. And again, we've actually had a lot of collaborative studies looking at APOL1 and preeclampsia. The 2 studies led by Charlotte Osapo and Robert Davis and Joyce Brown, looking at APOL1 variants. And so far, the very preliminary data suggests that fetal high-risk APOL1 variants may cause preeclampsia in the mothers, which doesn't make sense a bit back to front. We're estimating GFR. We've got cardiovascular, looking at the risk associated with APOL1 variants in terms of cardiovascular disease. A colleague at Duke is generating mature podocytes from inducible pluripotent stem cells from patients' blood so that he can then look at the effect of cytokines and other toxic agents on the APOL1 carrying podocytes. We're currently doing a study on the effect of dietary sodium and potassium on APOL1 nephropathy. We've published data showing an association between APOL1 and ingested toxin perfluoroalkyl compound, and also association with HIV, polyomaviruses and APOL1 variants, and then also as controlled studies of genetics of breast cancer in African women, and so on and so forth. So we've actually been quite active in terms of research collaboration. Again, a lot of our work has not only had ethical approval, but we have really made an effort to educate our community about why we're doing this research. And this is myself, my co-PI, Dr. Sapo, at a community center in the capital Accra, talking to the community elders about our study, the genomic study. And we're going to do this 2 weeks or so before going to then recruit. And we talk to patient gatherings, patient associations. We've had an active community engagement committee, and again contributed to making sure that genomic studies had comprehensive ethical framework. And then we also contributed. We're now struggling about whether, if we find individuals have got high-risk APOL1 variant, whether we should go ahead and give them that information, especially if we're not quite sure of the risk of developing CKD during their life course. So we're grappling with that at the moment. And then again, we've been very strong on data sharing and DNA. So if you have studies that you want to do around APOL1 variant, we'll be very happy to collaborate. And then just to end off, literally, it's now 3 months ago, there was a study showing the beneficial effect of a drug called inaxaplin for proteinuria kidney diseases in people with APOL1 variant. And inaxaplin inhibits APOL1, apolipoprotein L1. So it inhibits the whole protein, not just the variant. And so they tried this out in individuals with focal segmental glomerulosclerosis and showed that there was a significant reduction in proteinuria from 2.21 to 1.27 grams. The urine protein to creatinine ratio significantly dropped with inaxaplin over a 3-month period. And then also in those who were nephrotic, likewise, there's a drop in proteinuria. And similarly, with subnephrotic patients, there was a drop in proteinuria. And so this baseline and week 13 3-month assessment. So inaxaplin specifically inhibits APOL1 channel function in vitro. It reduces proteinuria. The study was only focused segmental glomerulosclerosis. And so the question that one has to ask is it likely to be of benefit in other APOL1 mediated kidney diseases? So I can start drawing up my conclusions if I may. So chronic kidney disease is common in Africans. And I've shown data that in Ghana, Nigeria, West Central Africa are the same from the data, but I didn't have time to go through all the different countries. That chronic kidney disease occurs at a younger age group in Africans, and that often treatment is either unavailable or is unaffordable for many Africans. So it's common in Africans, common in younger people where treatment may be either unavailable or unaffordable. I mean, we've shown that these APOL1 high-risk carriers, i.e. individuals with 2 APOL1 variants, um, significantly higher amongst individuals with chronic kidney disease, 30.6%, as opposed to normal, none of people without kidney disease, normal individuals of 25.9%, and that there's an association with chronic kidney disease of high-risk carriers, which has an odds ratio of 1.34, which is significant compared with low-risk carriers. I mentioned that we did not find an association between APOL1 high-risk carriers than in diabetes mellitus, and the risk of CKD then seems to be higher in African Americans than in Africans. And I think we've got explanation for that because the initial studies were probably of highly selected people, whereas we're studying a more general population. But nevertheless, we need to think about whether genetic admixture, haplotype background, or environment all contribute to the higher risk from APOL1 in African Americans. The role of the APOL1 variant, I think they're weights to be defined by the Apollo trial, so I mentioned that. And then there's a real exciting hope that the inhibitor of APOL1 in naxaplin may offer hope, the real hope of slowing progression of chronic kidney disease in individuals with two APOL1 risk variants. And currently there's studies going on world, at least in areas where there are a lot of Africans or people of African descent of trying out this drug. And finally, I'd like to thank the National Human Genome Research Institute and the NIDDK, again, National Institute of Health, for supporting us it's actually been over the last 11 years. We've been able to have meetings of investigators as well as study coordinators, lab technicians, data coordinators. It hasn't all been hard work. This is us at a meeting at Victoria Falls enjoying ourselves. So thank you very much for your attention. And I'm really grateful to be invited to share our data with you. Thank you.
Thank you very much, Dr. Adu. This was very detailed and very insightful, and the amount of work that seems to have been put into understanding these variants seems to be unsurmountable. I would like to welcome questions from the audience at this time. The panelists can go ahead and unmute themselves and ask Dr. Adu a question. And the attendees can use the Q&A chat box, of which I already see a question here, or the regular chat box to post their question for Dr. Adu. Dr. Bhima, can I have
yeah, thank you very much, Anwar. And Prof Adu, thank you so much for that very insightful talk. I mean, it's really something enlightening. You know, I just want to start off with some work that we did. And this was in the pediatric population, and it's going to throw the cat amongst the pigeons because our findings were completely different to some extent. So we looked at 10 candidate genes, one of which was the APOL1 gene, and this was in patients who had FSGS. All were pediatric patients. All of them had primary FSGS, excluded all the secondary causes. And surprisingly enough, the APOL1 did not come out significant. What we did find was about 39% had NPHS2 mutations. Okay. Yeah. But in the primary FSGS, which I assume the patients you showed were primary FSGS, right?
Yes, yes.
APOL1 didn't come out at all. In fact, there was only one patient that showed a heterozygous mutation for APOL1. So it seems slightly different in our population. And these were all indigenous Black patients. Okay, none of them were of Asian origin or Caucasian. So we are not able to demonstrate the impact of APOL1 on FSGS. What we did show was this high prevalence of the NPHS2 gene, and that when they did have the mutation, there was a more rapid progression to end-stage kidney disease, and that the response to immunosuppression, be it steroids or CNIs or anything, was like practically zero. You understand? I mean,
Yeah.
no, all of them didn't respond. So that was one thing. And then, as you know, Salah Naiker's group did a study where they looked at the APOL1 in HIV positive patients.
Yes, yeah.
And they showed a very, very high mutation rate. Over 70% of the patients had APOL1 mutations in the HIV group, and most of them were FSGS, right?
Yeah, yeah.
So I duplicated the study in the pediatric population in Durban, not with such a large cohort as what she had, but in a smaller cohort. And surprising enough, in fact, I presented that at the World Congress of Nephrology in Mexico. You awarded me the second prize. We didn't show a very strong association of APOL1, even in our HIV positive patients, biopsy proven.
Yeah.
So I couldn't understand why this was the case. And even Cheryl, I mean, we did the work with Cheryl Winkler at the NIH.
Yeah.
The thing is, we just couldn't explain why this was so. Do you have any reason to understand why in the pediatric population the findings are somewhat counterintuitive?
Yes, I mean, thank you very much. I mean, I kind of saw your papers and heard your presentation in Mexico. I mean, I think it's really intriguing. So, you know, that the differences, even within one country, South Africa, at least in adults and children, the association with HIV and FSGS, and the lack association in, you know, one part in adults, but not with children. I think that we need to learn a lot more. So there might be gene interactions, but within the same population, you know, you would have thought that probably there would be quite a lot of homogeneity in the genes within South Africa, but without looking, we can't say. And also with the children there, again, I think it's got to be gene, it could be gene environment, but it may be if you did enough DNA to try and get funding to do a genome-wide association study to see whether there were any genes.
Yeah, I mean, one of the things we thought about was linkage disequilibrium, you know what I mean? That could possibly play a role, see? But
So I didn't
must
get
say
that.
it's different. I say one of the things we thought about was linkage disequilibrium, you know, with these genes. If there's linkage disequilibrium and then you have a protective gene, that may actually overcome it. But I must say, no, it's difficult to prove that because you need a larger cohort, you know what I mean? And we didn't have that.
Yeah.
So yes, no, but I have to say that, you know, we didn't find this. And I discussed it with Sadla as well. And she said, you know, I know she just doesn't understand why that was so. Because, you know, I mean, I was really excited when her paper came out because it was halfway through our study. And she showed like a 70% mutation rate. And I said, you know, that's great. I mean, we got it made. But when we did the analysis, it was such a disappointment because we couldn't show any association.
Well, no, but I guess, I'm disappointed. But nevertheless, I mean, it's an original scientific observation. And it means that, you know, FSGS is not caused solely in Africa by APOL1 variant. And even our data show an odds ratio, I think it's about 1.8. So not all our subjects had high risk APOL1 variant. So I think your data really clearly shows the heterogeneity of disease within Africa, even within roughly the same population based on age. You know, so I mean, I think it's really data.
So I'm sorry, I don't want to hog the floor, but so Prof, I'm going to get in contact with you because I really want to take this forward. You know, Simon? And I want to take it forward in our pediatric population to see where it is. But thank you so much. Thanks, Anwar. I appreciate it.
That's a pleasure.
Thank you, Dr. Bhima. And speaking of Dr. Naiker, she is in the audience tonight. And she, first of all, Dr. Adu, she has thanked you for this great talk, but she has a question that is also along the lines that what Dr. Valerie Loixel has asked. That is there any evidence of efficacy of the SGLT2Is in APOL1 related CKD?
No, that has not been studied. To my knowledge, there have been no studies of SGLT2 inhibitors, in individuals with APOL1 variants. And the really surprising thing was that when you look at actually dapagliflozin, and the DAPA study, the one that I've looked at carefully, only 5% of the subjects there were Black, they call them Black. And I'm not sure that they've actually analyzed the APOL1 variants in them and whether there were enough to be able to show an effect. But obviously a proportion of them would have had. So that's a very good question, and we can maybe write to the authors and see whether they've done genotyping in the Blacks in that study. Thank you, that's a good question.
And just a follow-up to that question, additionally, Dr. Valerie had added the ACE inhibitors to the same question. Would you happen to comment on that?
Again, I think the study that did that was the CRIC study, and there did not seem to be any difference in terms of those individuals on. They didn't sub-analyze for APOL1 variants. I've got to be careful here. So there was protection whether you had APOL1 variants or not. But please look that up because I can't recall that absolutely.
Well, thank you, Dr. Naikar and Dr. Valerie, for your great questions. So we have another question from Dr. Bassi, who's also in the audience. The inquiry is that how does the presence of the APOL1 high-risk variant result in nephropathy in terms of the pathogenesis?
Yeah, no, thank you again. That's a really great question and an area that's been highly studied. So currently, APOL1 variants are found in podocytes. And the best podocytes, as well as tubular epithelial cells and also blood vessels. And the best explanation so far is that it causes channels, chloride channels within the basement membrane to open up, and that then leads to damage. But there's several potential causes, and at the moment it's not known. But the most plausible hypothesis is that it causes channel opening, chloride channel opening, both in the cell membrane and also in mitochondria. That leads to damage.
Thank you very much. And there's another interesting question in the Q&A box. And is the APOL1 associated with any other diseases apart from kidney diseases? This is from Dr. Akrabi from Tanzania.
Again, that's a really good question. There have been some studies that suggest that it's associated with high blood pressure, and also some studies that it's associated with atheroma, cardiovascular disease. Again, these are all individual studies, so as yet that is not established.
Thank you very much. And I believe we have a member of your team actually commenting on your presentation. Thank you, Dr. Adu, for a wonderful presentation, indeed showing the work we are doing in Africa so glaringly. I'm indeed very proud to be associated with the H3 Africa study. This is from Ifeoma Ulasi. And again, from Dr. Valerie, are there any plans to include Africans in the new gene therapy studies?
People aren't doing gene therapy studies. It's a drug study. So yes, there are plans to include Africa in inaxaplin, the drug treatment study. Yes, indeed.
Thank you, Dr. Adu. I get into a lot of trouble with Elliot for asking him to unmute and talk. He's actually posted a comment, but Elliot, we would love to hear from you.
Thank you very much. And all I wanted to say is that great presentation, Dr. D. I really loved it. And I think the other issue is about the drug so far. And I think after the New England Journal of Medicine study as to the fact that there could be a possibility that these drugs could be used potentially for, APOL1 homozygotes. So now the plans advanced now to, I think, the VETEX study or so. And I think I'm happy to say Ghana is one of the sites that will be considered. So I think that the plans advanced. And we are really hoping and praying that we'll be able to recruit a lot to be able to come up with as to whether or not this medication would have some effect on proteinuria or maybe progression of kidney disease. Thank you. And don't be putting me on the spot.
Thank you, Elliot. And there's another question, if you'd be happy to take one more before I hand over for the closing. This question is, would it be safe to assume that some forms of idiopathic GN are related to APOL1 disease?
I mean, I think the answer is yes. Obviously, we've shown that in our study, focal segmental glomerular sclerosis is associated significantly with APOL1 mediated disease. And then some of the studies have suggested that maybe membranous nephropathy is also associated with high-risk APOL1 variant. I think in our study, we showed no association with membranous or with minimal change, but showed an association with focal segmental glomerular sclerosis. So our numbers, we had something like 300 children with minimal change, still not a large number in terms of genomic studies. But so to answer your question, I think possibly, but we have not found that. Thank you.
Ifeoma, I've given you permission to talk to, please.
Thank you very much for giving me permission to talk. Yeah, thank you very much. Wonderful presentation, Dr. Edu. I'm just looking at the aspect of our transplant patients who may have APOL1 double allele, either as a donor, as a recipient. From your talk, you're suggesting we should wait until the Apollo study gives their results. Do you think, I don't know, it means that some people who could benefit from not giving their kidney or receiving such kidney would not? Yeah. Just to hear your perspective to that.
Yeah. No, I think, Ifeoma, and that's a very, very valid point. And I find myself being conflicted whenever I think about it. But we know, for example, that 35% of ACANs in Ashanti have 2APOL1 risk variants, and 40% of Igbos from your neck of the woods have 2APOL1 risk variants. So if you look at the, reducing your potential donor and recipient pool by 60%, that actually has huge implications. And that's why I think we should await the results of the Apollo study. But equally, I take your point that it would be a real tragedy if somebody gives a kidney and they've got 2APOL1 risk variants and then subsequently ends up with chronic kidney disease, and their donor again ends up with allograft failure. So it's a really complex question. And I think Apollo is recruited, I think, reasonably well, and they should be able to give us an indication, hopefully in 2 to 3 years. But that's why I am conflicted about the advice you give. And of course, once you bring up the question of screening for APOL1 variants, and you find that somebody's got 2 variants, what do? You tell them they can't have a transplant?
Yeah.
Or they can't? Yeah, so it's a real...
So for now, we shouldn't screen for APOL1 for our patients going for transplant.
I think we should wait for the Apollo study, and maybe a future, somebody in the past who worked with H3 Africa is in the Apollo study, we could write to them and say, are they planning an interim data analysis? Because it's a really, really critical point in countries where 40% of people have 2APOL1 risk variants. Thank you, Fiona, for bringing that up. I've been agonizing.
Thank you very much.
With our own program.
I would just like to invite a comment from Dr. Rasha Darvish, if you would like to say something, Dr. Rasha.
First of all, I am really impressed by the magnitude of the study and the effort which was done. I mean, you really make us proud, Dr. Adu, really, we are really proud. And I really just have a very simple question, actually. You kept saying that you have the age in which African patients develop CKD in Africa is much earlier in comparison to other countries. And you said because of hypertension. So don't you think that we should just simply focus on prevention and proper treatment of hypertension, maybe to deal with this simple point? I mean, genetics is beautiful, but again, we are far away in Africa to be able to make it affordable for everyone. So why not just focusing about hypertension as such and to control it properly? And another question is, did we kind of relate that to the magnesium? Because there are many papers talking about simple magnesium insufficiency related to hypertension. Do we have this in the background? Did we kind of compare that to the magnesium level in these patients?
Thank you very much for two really, really important questions. And in response to your first question, the answer is yes, yes, yes. We really should focus on screening, and we've shown that we can screen individuals for chronic kidney disease. We can certainly screen for hypertension, not necessarily as a research project, but just our polyclinics and our hospitals to screen, go out and screen apparently healthy individuals for hypertension, and then treat that. And you're right, that's going to be much more effective than using an inhibitor of APOL1. So no, I take that point completely. And the second thing is we have not looked at magnesium, but as you raise it, as I said, one of the key things that we did as a consortium was to store DNA and blood and plasma and serum. So we can go back and look at that or collaborate with somebody who's measuring, magnesium in a research way to look at that. But thank you very much, Dr. Darwish, for those really important questions.
Thank you. Thank you for a beautiful talk. I really enjoyed it. Really, it was a pleasure, Dr. Adu. Thank you so much.
Thank you.
Thank you so much, Dr. Dr. Adu, I would really, really like to thank you for joining us again this evening, taking your precious time out and speaking to our small community that we have here tonight. And I would also take this opportunity on behalf of the Africa Healthcare Network to thank the International Society of Nephrology for arranging this talk and collaborating with us. For Tanzanian participants claiming CPD points, we have posted the link on the main chat box, so please feel free to sign in and claim those points. We will also have a video of this talk up on our YouTube channel, the Africa Healthcare Network Fireside Chats. This should be available by Monday, so we will share the link and hopefully it will be shared further by all of you. I would like to request Dr. Lloyd to come in for the closing remarks. Dr. Lloyd.
Thank you very much, Professor. It was a wonderful session, a complete exposition of all the wonderful work that you've done. So much of molecular work and very innovative work as well. I have a small little, is there I think it opens up the box for a lot of collaboration that can occur. Just that if for L1 can be looked in East Africa, we would be very happy to actually collaborate. And especially there'd be a lot of interested people in Rwanda, Tanzania, Kenya, so I could connect and we could do something on that side. And the other thing is whether you could have point of care testing that can be developed with this, to identify if this does exist in other parts of Africa as well. Thank you very much for this wonderful session.
Thank you for those kind comments. We're very eager to collaborate. So you just need to get in touch. Thank you.